I am Dr. Bharat Koyani, MD pathologist, residing in Rajkot, Gujarat, India. Today we will discuss a clinical case. A poor laborer family from South Gujarat, tribal area of South Gujarat, migrated to Amreli district of Gujarat, which is 500 kilometers away from the tribal area. Amreli is a non-tribal area. A 22 years old female patient presented to a general practitioner with acute pain in right upper quadrant region of abdomen, fever, icterus, pain and tenderness in the extremities. Investigations were serum bilirubin total was 6 milligram percent, direct was 5.5 milligram percent, indirect was 0.5 milligram percent. SGPT was about 1000 international units per liter. Hemoglobin was 7 gram percent. Total count was 18,000 per microliter. Smear shows neutrophilia. Considering the viral hepatitis, general practitioner prescribed medicine for 7 days. But at the end of 3 days, patient came with severe acute abdomen. She was referred to a MD physician. Physician examined the patient, again requested investigations to pathologist. Serum bilirubin was about 6 milligram percent. Direct was 5.5 milligram percent. Indirect was 0.5 milligram percent. SGPT was about 1000 international units per liter. HbA1c was negative. Physician advised as a viral hepatitis and prescribed medicine for 15 days. But at the end of 3 days, again patient came with stupor, semi-consciousness. Physician advised investigation to another lab, to a pathologist. Serum bilirubin and SGPT was about the same as the previous reports. In CBC, hemoglobin was 7 gram percent. Total count was 20,000 per microliter with neutrophilia. As soon as pathology examined the smear, he saw 7 to 8 sickle cell per high power field. As the report was asked urgently, he immediately rang to the physician that, "Sir, it is a sickle cell anemia." But regrettably, physician told to the pathologist that due to the poor condition, clinical condition of the patient, she was referred to higher center, but after 30 kilometers away, patient died. Now, we will discuss this case. Now, whether it was a viral hepatitis or not. Now, seriousness of the patient denies the viral hepatitis, pure viral hepatitis. Whether it is a combination of sickle cell anemia with viral hepatitis? No. If there is a combination of these two conditions, direct bilirubin will be very high Sometimes it may reach more than 50 milligram percent direct bilirubin. So it was a pure case of sickle cell anemia. Now, why the bilirubin and SGPT was high in this case? Due to the vaso-occlusion of the microcirculation of the liver, there will be compression of the biliary canaliculi and necrosis, hypoxia in the hepatocytes. This will cause regurgitation of the direct bilirubin into the systemic circulation, and necrosis of the hepatocyte will pour SGPT into the circulation. So we can explain why the direct bilirubin was high in this case, even though it was a hemolytic anemia. SGPT was due to the necrosis. Now, what may be the cause of death in this patient? Due to the vaso-occlusion in the lungs and perhaps due to the necrosis in the bone marrow, the emboli of the fat might have lodged into the lungs, which caused hypoxia, generalized hypoxia all over the body. And we know that hypoxia will precipitate sickling all over the body. So there was a multi-organ sickling, and due to multi-organ failure, patient died. This is known as acute chest syndrome as far as the sickle cell anemia is concerned. Now, what should be the lesson of this case? Now, here the patient was from tribal area of South Gujarat, which is an endemic zone of sickle hemoglobin. Almost 11% of the tribal population is having sickle cell trait, sickle hemoglobin trait. So each and every patient, whatever may be the cause, should be screened for sickle hemoglobin. Second point, we should know the bilirubin pathway perfectly. In our mind, direct bilirubin, presence of direct bilirubin means hepatitis. Presence of high indirect bilirubin, presence of hemolysis. This is not the case. We should know why direct bilirubin is high, why indirect bilirubin is high. It is a permutation and combination of the clinical condition. Second point, the laboratory reports which showed high direct bilirubin and SGPT high, they misguided the clinician to diagnose viral hepatitis. So there is an inference that the laboratory reports are adjunct to the clinical history and physical examination. They are not alternatives of clinical history and physical examination. So today's message is that we should thoroughly concentrate on sickle cell trait, anemia, and the bilirubin pathway. Thank you very much.